I think without much ado, I think we'll start the session so that we finish in time also. So welcome to all the esteemed faculty and the delegates here. So may I know who are the speakers here? Can they raise their hands? Dr. Ranjit is also there standing outside. I think we can start probably. Pallavi Singh is there? Okay. And Preet Kamar, yes, you can start. Huh? Please. So Dr. Preet Kamar is from Patiala and he's speaking on optimizing patient satisfaction pre-cataract surgery fundus examination. This is a very important subject for all of us. Dr. Preet Kamar, please. Yeah. In the meantime, we can have the next. Yeah. Dr. Pallavi, you can be ready with the talk next. Eh? Welcome. Welcome from DMC.
Should I start, sir?
Yeah, please.
Yeah. Good morning, all. I would like to thank AIOCMTC4 for giving me this opportunity to address your August gathering. So I'm speaking on ensuring patient satisfaction, a pre-op fundus examination. Cataract is one of the leading causes of visual impairment. Pre-op evaluation is crucial. Like ocular surface disorders, if not addressed pre-surgery, they will lead to an unhappy patient. So fundus examination should be a must-do in optimizing the post-op results. Why so? We have evolved from ICC to ECC to SICS to minimal incision cataract surgeries. From local to topical anesthesia, from monofocal, we have a myriad of lenses, multifocals, trifocals, extended depth of focus. So in the era of femtosecond lasers, wavefront technology, intraoperative aberrometry, focus is not just 6/6. So why do we need to examine the fundus? To assess the retinal and optic nerve health, to exist coexisting pathologies like diabetic retinopathy, ARMD, RD, glaucoma, for an accurate visual prognosis and patient counseling. What are the challenges in cataract patients? Mediopacities can obscure the fundus view. Dense cataracts make visualization difficult, so we need alternative imaging. Fundus can be examined by direct, indirect ophthalmoscopy, a slit lamp biomicroscopy with a 90D or 78 diopter lens, a B-scan ultrasound in dense mediopacities, by OCT scanning, fundus photo, wide field photo, OCT or Opta. B-scan is indicated when the fundus view is obscured. It's useful in dense cataracts, suspected retinal detachment, intraocular tumors, and vitreous hemorrhage. The common findings which impact prognosis: macular scar, there'll be a poor visual recovery post-op. In optic atrophy, there's a limited visual potential. In AMD, the patient may complain of distorted vision or limited improvement. DME needs treatment before or with cataract surgery. So let's come to some examples. We had the 60-year-old female came to us with a vision of 6/18. On pinhole, she improved to 6/9 parts. Had fundus not been examined, had OCT not been done, who would be responsible for the poor visual recovery after cataract surgery? So she basically had a lasered BRVO with an ERM with a lamellar macular hole. She was given an option of a combined surgery versus cataract and observation. She chose only cataract surgery. We observed for the ERM for now. Another 65-year-old female came with significant cataract. On examination of fundus, she had an ERM with lamellar hole epiretinal membrane proliferation. So she was advised a combined cataract with vitrectomy. Another 55-year-old female, recently diagnosed diabetic. In the right eye, she had 3/60. On pinhole, she was improving to 6/18. The other eye on pinhole improved to 6/36. We examined fundus, did the OCT. Right eye showed retinal thinning, which was suggestive of macular ischemia, while the left eye there was ERM with VMT. Another 56-year-old female, high myope, came for the clear lens extraction. On fundus examination, the left eye showed asymptomatic polyps. She had a tall, peaked, heterogeneously reflective PED. She was advised anti-VEGF followed by cataract surgery. Another patient, he had a scarred CNVM, so was undertaken for cataract surgery after explaining a guarded visual prognosis. So let's come to specific cases. Cataract surgery in diabetics. We all know diabetics develop cataracts early. The most common type is senile. Snowflake cataract can be seen. Patients who have a pre-existing untreated PDR, they are more likely to progress, develop vitreous hemorrhage after cataract surgery. Therefore, PRP is recommended preoperatively if the media allows. If not, these days we give anti-VEGF after ruling out tractions. Combined cataract surgery with PPV may be undertaken for cases with a dense VH, macula threatening or involving TRD, combined RD, taut posterior hyaloid. In patients with pre-existing DME, cataract surgery increases the risk of progression or redevelopment of macular edema in about 20 to 50% of cases. So therefore, it should be adequately treated before surgery with anti-VEGFs or steroids. DEX implant has shown a significant improvement in CSME over 3 years. A lot of studies are available. Another study which highlighted that the risk of DME progression was seen in almost all grades, about 1% in no DR, 5 to 13% in the various grades of DR. DME increased sharply in first year after cataract surgery. Post-op CME chances are also higher in these patients, so pre-op use of NSAIDs may reduce these chances. Hydrophobic acrylic IOL has the least chance of PCO and silicone oil adhesion, so should be the IOL of choice. In patients with PDR but with an NVI, they need prompt treatment to induce regression of NVI with anti-VEGF with PRP or cryo. Phaco should be considered with PPV at the earliest, with or without PPV, to enable adequate treatment of the posterior segment pathology after regression of NVI. Combining Phaco-TRAB may be planned in cases with coexisting NVG when NVI has regressed. So this table summarizes very well in patients of no to mild stages, standard Phaco can be done. Moderate to severe, Phaco with pre-op NSAIDs. Mild to severe NPDR, but DME is present, first treat anti-VEGF. In PDR, with or without DME, anti-VEGF, PRP, a combination may also be indicated. Coming to peripheral retinal degenerations, degenerations which predispose to RD are lattice, snail track, degenerative retinochiasis, tears and holes. Lesions which predispose to RD in a patient with recent onset flashes and floaters should not be ignored. Lesions predisposing to RD in patients undergoing refractive, cataract or intravitreal injection should be treated pre-op. And a patient advised for refractive surgery, check for PVD symptoms. If they are present, treat if you detect lesions. Defer the refractive surgery, treat only after 2 to 3 weeks. This also summarizes the preferred practice pattern, that lattice degeneration but with no flashes, floaters but undergoing intraocular surgery should be treated before. Retina examination prior to intraocular surgery or laser or intravitreal injections. Everyone should undergo a dilated fundus examination. Peripheral lesions need to be treated and the procedure can be undertaken after 2 weeks. So I'll conclude by saying, avoid multifocal or extended depth of focus IOLs in patients with macular pathology. In patients who are undergoing premium surgeries, do an OCT invariably. And as the age goes, if we diagnose it before surgery, it's the patient's problem. But if we diagnose it after surgery, it's our problem. Thank you.
I would like to call upon Dr. Pallavi to present from OCT to injection, practical approach in the management of DME in daily practice.
We'll have the discussion. I think it's a very important topic. We'll have it later.
Dr. Pallavi is working as an assistant professor in DMC Ludhiana.
For the kind introduction. I would like to thank AIOS and POS for giving me this opportunity. I'll be discussing on the management of diabetic macular edema. It's not move.
Not working?
Slides are not moving, please check.
Yeah.
Started.
Yeah. So diabetic retinopathy is a common microvascular complication of diabetes, and diabetic macular edema is a common cause of blindness in people of working age and can develop in both type 1 and type 2. So the pathophysiology is the chronic hyperglycemia, which causes damage to the retinal vessels and breakdown of the blood-retinal barrier and hence fluid leakage and accumulation. Now it's well established that both inflammatory mediators and like interleukin-6 and TNF-alpha along with VEGF play a role in the pathophysiology, and early treatment can control inflammation and prevent the development of edema. OCT is the most important imaging tool for diagnosis, management, and prognosis of DME. So the concept of center involving DME is important. So when there is intraretinal, subretinal fluid or thickening involving 1 millimeter diameter from the fovea, it's center involving. Then again, looking at the OCT classification of DME is important to take a decision whether a medical intervention would help or whether a surgical intervention would help. So in spongiform thickening, cystoid macular edema, serous retinal detachment without a taut posterior hyaloid, a medical management would help. And whereas in a taut posterior hyaloid without TRD or with TRD, we need to intervene surgically. So points to consider in patient management is the baseline visual acuity, duration of DME, because chronicity will affect its responsiveness and will help us in prognostication. The ocular environment and local pathological changes like ERM and systemic factors. So management options we all know are anti-VEGF, steroids, laser, as well as vitrectomy. So how do we proceed when we face a type 2 diabetic patient with DME? This is a very good flow chart which summarizes how we should take into consideration the management of such a patient. So to simplify it, steroids should be considered as first line in pseudophakic patient if a cataract surgery is planned, if there is a central serous retinal detachment, hyperreflective foci, extensive lipid deposition, vitrectomized eye, recent history of MI or stroke, pregnancy, and if there are chances of poor compliance and patient is unwilling for frequent injections. Anti-VEGF should be considered if there is concomitant PDR, if there is presence of rubiosis and uncontrolled glaucoma. Anti-VEGFs are considered as the first-line therapy and are effective, but the major concerns are in patients who have extensive fibrovascular proliferation. Obviously, it will lead to a crunch phenomena and TRD, systemic concerns, and then non-responders, persistent edema, rebound, and resistance. Non-responders in cases of anti-VEGF are about 1/3, whereas steroids is about 1/6, and around 1/3 to 2/3 DME patients fail to achieve complete resolution even after 1 to 2 years of intensive anti-VEGF therapy. Protection of foveal photoreceptors is the key to achieving maximum visual acuity potential. So why some DME patients are insufficient responders to anti-VEGF? There are ceiling effect, there is inadequate treatment, then systemic factors play a role, then maybe they have predominant inflammatory mediators, delay in treatment response, then some OCT biomarkers which I'll be discussing in the subsequent slides and post-vitrectomized eye. Suboptimal responses to anti-VEGF therapy can be tackled with more frequent doses, switch to an alternative anti-VEGF, switch to corticosteroids, or a combination therapy or consolidation with focal laser. So Ozurdex comes to the rescue here. It has advantages of good response in refractive DME, fast-acting, long-lasting effect with minimal systemic absorption. The transient IOP rise and cataracts are the concerns here. If the patient is non-responder, what we need to look at? We need to look at the systemic condition of the patient, then ocular factors also, then OCT specific biomarkers. They are very important with the advent of newer OCT machines. They help us decide which treatment will work better and the prognostication. So traditionally, if we look, we have been looking at these presentations of DME like spongy thickening, cystoid edema, neurosensory detachment, and tractional. But there are studies which have given us insights into other entities as well. So there are non-center involving DME, center involving DME with CNP areas and with CNP areas having the EZ defects. Then intracystoid hyperreflective material, cystoid degeneration, middle limiting membrane hyperreflectivity. Then more than central retinal thickness, there are other entities also we look at, which is like subfoveal neurosensory detachment, which indicates local hypoxia, compromised ELM, and which leads to reduced retinal sensitivity. Then CME, which is because of the elevated VEGF and breakdown of the inner retinal blood retinal barrier. Then disorganization of retinal inner layer, increasing duration of DME, it results in worsening of inner retinal morphology. Hyperreflective foci. So they respond better to corticosteroids. Then outer vitromacular interface issues like tout posterior hyaloid and vitromacular traction and non-tractional DME, outer retinal layer disruptions, then again it is related to poorer outcomes. So this is a case which shows an example of a patient who had intact outer retinal layers and showed a good recovery to anti-VEGFs. And then again, this is a case where anti-VEGFs were given, but despite of anatomical resolution of CME, the vision did not improve much. Focal laser has still got a role in the era of anti-VEGFs in non-center involving DME. So this is a patient, she responded, focal laser was done in this patient in a 6 months follow-up. The visual acuity improved to 6.9. So it can be considered in focal non-center involving DME, succinate maculopathy, and in consolidation therapy along with intravitreal pharmacotherapy. So vitrectomy for DME is considered in the cases where there is anterior-posterior traction and tangential traction when it is not responding to anti-VEGF or dexamethasone. But then there are cases where vitrectomy has a role in non-tractional refractory diabetic macular edema as well. So the conclusion is tailoring therapy for the best outcomes, tailoring treatment to patients considering the non-ocular factors as well, and tailoring treatment to patient considering the ocular factors. So in conclusion, DME management is complex and multifactorial. Approaches to treating DME vary broadly. Economics and resources play a role. Systemic control, comorbidities, and genetic factors also play a role. So we have to individualize the treatment. Thank you.
Thank you, Dr. Palvi, for summarizing such a vast topic in such a short time. I think the issues which we are discussing today, they're all very important, and maybe we can leave the discussion to the end because I think most of the retina surgeons around. So OCT biomarkers in uveitis, Dr. Ravinder Malli. She is a senior consultant at Dhami Eye Hospital, Ludhiana, and she has a interest in vitretina and uvea.
Good morning. At the outset, I want to thank AIOS and POS for the kind invitation, and I'll be speaking on this very interesting topic of OCT biomarkers. Now, after Dr. Palvi's talk, we all have realized that OCT is so important, and the OCT biomarkers we all are aware in diabetes and in ARMD. Let's talk about the role of OCT biomarkers in uveitis now. So what is an imaging biomarker? It is a measurable imaging feature that can provide information about presence, activity, and severity of uveitis. It helps us to diagnose, monitor the response, and prognosticate or guide the treatment of uveitis, and thus helps to differentiate infectious from non-infectious uveitis and helps at planning a personalized treatment and preventing complication by detecting the subclinical complications. Now coming to the differential diagnosis, first I'll talk about weak age disease. This is a young lady presented with multiple neurosensory detachments, and other eye was normal. You can see the optic disc in the left eye is normal and right eye is normal, and the left eye has disc edema with serous detachment. Angiography showing the typical features of VKH, and let's see what OCT tells. So there are remarkable features which can diagnose VKH on OCT. You can see this is a disease which involves the choroid, and there is diffuse choroidal thickening with choroidal granulomas leading to RP undulations. There is a bacillary layer detachment along with neurosensory detachment, multiple septae, subretinal hyperreflective dots, and disc edema with choroidal thickening and multiple granulomas. As compared to bullous CSR, you can see the difference is remarkable. You don't see RP undulations and hyperreflective materials and bacillary layer detachment in CSR. There is a clear fluid between the neurosensory in the area of detachment. Another patient of VKH with bilateral disc edema with serous RD, you can see hyperreflective, subretinal hyperreflective material in the left eye, which is a sign of activity. In the previous patient, OCT helps to monitor the disease activity. Within a month, you can see there is remarkable resolution of the all the features which you are seeing on OCT, and she is doing well. The RP now undulations have gone, the choroidal architecture is coming back. Again, this is seen on the octa also. You can see the choriocapillaries coming back. In the previous upper slide, you can't see the choroidal architecture. So this is on follow-up. Another patient of similar VKH with poliosis, and she came 15 years later with recurrence, and this time the fundus picture was not very remarkable. There was no serious detachment, but on OCT it clinched the diagnosis: bilateral RP undulations with multiple granulomas, choroidal thickening on B scan. So there is a disease activity going on, and she started on immunosuppressive therapy. Now coming to next, toxoplasma retinochoroiditis, where OCT plays a very important role. Now you can see this is 19-year-old boy presented with this single lesion. There is no healed scar adjacent to this. This is a acquired toxoplasma infection. So here the OCT gives a very characteristic look. You can see these inner layers are hyper reflective. They are bright, looking very bright, and there is loss of the retinal architecture with back shadowing, and the overlying hyaloid is detached and thickened. So this is on follow-up after institution of specific therapy. There is a remarkable resolution, and as the patient was picked up very early, the visual prognosis was good, and it was away from macula also. Another patient, 52-year-old female, presented with this type of picture. It was looking like an endophthalmitis kind of picture. There was almost panuveitis, significant vitritis precluding the view of retina, but very hazily you can see something in the macular area. Now in this OCT cleanser diagnosis, because this patient was referred from somewhere else, diagnosed as fungal candida albicans related endophthalmitis, and was advised surgery. Now when she presented here, we did OCT, and you can see there is a significant alteration of the retinal layers, and this is very characteristic. As I'll come back to the fungal one. These are the features of toxo. You can see intraretinal hyperreflectivity, very bright, and this is suggestive of active lesion. Posterior hyaloid thickening and detachment, choroidal shadowing, retinal layer disorganization and disruption, and in the late stage leading on to RP atrophy and scar. And this is how the OCT looked like over follow-up as the lesion resolved. So now coming back to the candida endophthalmitis, because if this lesion is in the central area, this can very much mimic the candida endoph, but the OCT in both are very different. In the candida endophthalmitis, you can see the lesion. There are two type of presentation. The first one is from the retinal layers coming to the vitreous, and in the other it is opening up into the vitreous cavity, and candida has propensity growing towards the vitreous. So this will always come from posterior to anterior, and this is giving a typical rain cloud appearance. So it was very different from the toxo, and in the toxo you can see the lesion is very well demarcated, and there is involvement of the retina and choroid, but it is not coming into the vitreous. So now coming to syphilitic uveitis, another 52-year-old female presented with the upper one left side picture. You can see she had vitritis, and she was referred 3 weeks later with worsening of vision to me. And at the presentation you can see there are tongue shaped lesions which are looking like a viral retinitis. So she was started on antiviral therapy. Meanwhile, she was advised PCR, but she was reluctant. But the lesion started worsening over next few days time, and these focal lesions, these medullary kind of lesions started appearing, which are very typical of syphilitic retinitis. But this patient was unmarried, and she was a very highly educated principal of a school, and there was no clues that we should do TPHA testing. But looking at this picture, and if we pass a OCT scan through these lesions, this is very typical. So that can clinch a diagnosis at this stage, but the lesion was peripheral, so it was difficult to do at that stage. now you see the retinitis is progressing. In the meantime, we got TPHA VDRL done, which came out highly positive, and she was treated as neurosyphilis with 2 weeks of IV cefotaxime with oral steroids, and this is how the lesion resolved. So at this stage, I took the OCT, so that showed hyperreflective dots which are present in the inner layers, and there could be tongue-like projections which project towards a deeper layer, and the large round hyperreflective spots. There are intraretinal layer in inner retinal layer involvement, and sometimes there is full thickness retinitis, and ultimately it leads on to RP thickening, irregularity, and disruption, leading to loss of ellipsoid zone. In later stages, there is RP atrophy and thinning of the in the healed lesions. Another patient, this male patient in 50s, presented with the serpiginous type of choroiditis, but on follow-up, he was MON2 positive or started on steroids, ATT with steroids, but the lesions kept on worsening, and then you see these miliary lesions coming up at the border of, advancing border of, which was looking like a choroiditis, but actually it was retinitis. Now, when the OCT was passed through these lesions, you can see very typical hyperreflective dots involving the RPE, and there is an area of retinitis in the OCT. So that cleans the diagnosis, and he improved over follow-up. Another lesion where OCT is very typical is a PIC lesion, that is punctate in a choroidopathy. And in this, you can see the RP elevation with disruption of the outer retinal layers. There could be accumulation of hypo or hyperreflective material, and the active lesions RP elevation is with inflammatory elements. There could be subretinal, intraretinal fluid, and very high propensity of formation of a choroidal neovascular net, which was very well seen on OCTA in this patient. And the management changed to intravitreal anti-VEGFs. And another patient of similar nature, she was given steroids with immunosuppressive therapy because she kept on having recurrent CNVM. Another young patient with sarcoidosis diagnosed on OCT as choroidal granulomas. Yes, I'm almost going to finish. So in Behçet's disease, the areas of retinitis are very well visible, and they help in making our diagnosis easier. I want to show just one patient of retinitis. This patient of Behçet's on follow-up started worsening, and with this area of whitish retina, and OCT passing through this area showed hyperreflective inner retinal layers suggestive of retinitis. So the immunosuppression was hiked up, and intravitreal DEXA was given, and she improved on to this level. So similarly, OCT can be seen to diagnose optic disc edema. In vitreoretinal lymphoma, it gives a very typical appearance of sub-RP bumps, and all these, now you can see different types of OCT involvement in infectious and non-infectious uveitis. It can help to differentiate and then guide the personalized treatment, local versus systemic therapy, and biologic versus steroids, or surgery in case of vitreoretinal traction, and prevent complications like CME, glaucoma, CNVM by detecting subclinical disease activity. Thank you so much.
Thank you, Dr. Mali, for an excellent overview of everything. These are very important points actually. We'll have the discussion on this. So now we call upon Dr. Nishant. He is going to speak on a topic which is very close to my heart also, and probably Dinesh's also. So ROP in private practice. Wonderful. That's what we are doing. No?
Dr. Nishant is a vitreoretina surgeon and ROP consultant in Bansal Eye and Retina Center, Chandigarh.
Hello. 10 years back when I finished my fellowship, I was very well trained at Shankar Netralaya, and a good mentor taught me about ROP. She told me wherever you are going, you have to do ROP. So when I came to Chandigarh, when I consulted some of the very senior private practitioners, they taught me one thing: Doctor Sahab, aapa pange nahi pehna, aapa ROP nahi karna itte. But I went against them and I set up a ROP practice of my own. I would be covering under these few topics. So as I said, the first thing is good training. Good training, before you do ROP, a good training is very important. And not only ROP, we should be knowing some aspects of neonatology as well when we are dealing with these babies. And hands-on for laser and intravitreal injections if it's possible for ROP cases. At least if we have interest to do ROP, we should do medical retina, which includes lasers and anti-VEGF. Attending regular ROP webinars, CMEs and conferences is important. And also we should be a member of ROP society. Next is proper equipment is required, though it's not a very costly equipment. Any retina person would be having these in his armamentarium. So an indirect would be required, 20 diopter or a 28 diopter lens, speculum, indenter, green laser. All retina, any person who's doing retina would be having this green laser. Only additional thing which would be required would be a LIO. So that won't cost much. And I have a dedicated staff who handles my laser whenever I am traveling for ROP lasers. And portable fundus camera, or even nowadays we can click pictures through our mobile devices. So this is what I carry in my ROP screening bag, which is already discussed. And I have a dedicated person who's packing my ROP laser with all the thermocols so that it doesn't get into a jerk. It's properly packed. Sound nahi aa raha. Music. And this LIO is properly packed with all its curves, avoiding sharp bends, because this is the most delicate thing. Any sharp bend can break the LIO. And this is my indirect ophthalmoscope bag. And the same person attaches all my lasers and LIO and in the NICU setups, and we are able to do the lasers. Video of how I do intravitreal injections for these ROP babies. Initially I was doing these ROP injections in the OT setup, but nowadays I have started doing it in NICUs only in the warmer. So baby has to be nicely wrapped before the procedure, because sometimes OTs can be very cold. So proper wrapping of these babies. For intravitreal injections and adult size, because we don't have these small eye drapes, these adult eye drapes can be used, which can cover both the eyes simultaneously. It can be covered. A drop of paracrine on the betadine, cleaning with the betadine solution. It's 1 ml from the limbus and half the dose of adult dose. I prefer Avastin in these babies. The needle should be pointing towards the optic nerve. It's parallel to the nimbus and not perpendicular. And to avoid full penetration for these babies. Change the gloves, keep the same trolley. The assistant also changes the gloves, and the injection is performed similarly to other eyes as well. You have to stay stabilize the eye with bugs because the baby is moving, the eye is moving. Always examine the baby the next day whenever you have injected the babies. Whenever we are starting to do ROP, we should explore level 3 NICUs nearby our place, and we should have a good reputation and rapport with our neonatologist and pediatrician friends. Sometimes government hospitals also outsource ROP specialists because sometimes ROP specialists are not available in the government setup, and we can organize CMEs. Proper documentation is very important for ROP. Before doing ROP, we should have all the consent forms, bilingual, trilingual, for screening, lasers, anti-VEGF injections. These are available with the DOS and the AIOS consent forms. All these are the consent forms and the screening forms which should be available. Medical indemnity is very important. I think medical legal aspects will be covering later on during these presentations. And I personally have an indemnity of 1 crore because I am doing ROP. And in one of the conferences, it was told like if you are practicing ROP, the cost of 2 BHK apartment should be the cost of your indemnity. And whenever we are in doubt, don't hesitate to refer to your friend, higher center, take a second opinion. And counseling is very important for the parents before we are screening and treatment. It's very important. In their language they understand, and we have to be keep updated with the latest ROP literature, and if possible to take photos or draw diagrams. Thank you.
Thank you very much. Excellent. Very, very practical. Before we proceed on to the next speaker, I think I'll just take one comment from Dr. Ajay Kapoor, who is a pioneer in this part of the country for RP. Any comment? One comment. Any comment, whatever wise words from you.
No, I'm talking about Chandigarh. Now it's still gone high. Recently it's gone very high. Yeah. True.
Yeah, that
True.
is true.
Yes.
That is true.
It's true. Yes.
It's not something to be afraid of. You have to
Yes.
be careful with your record keeping. You have to be polite. You have to inform the parents also. Sometimes they are rude also. You don't have to be rude in turn again. And you know what is the equipment required for ROP? I think the will to do ROP. Okay, you can call the next.
Thank you, Nishant, Dr. Ajay Kapoor, and Dr. Vipin for the nice advice. So now we go on to the next speaker, Dr. Sushant Madan. Multicolor imaging, a new perspective to imaging and documentation. Sushant.
Sushant is learning ROP from me nowadays.
Hello, good morning everyone. So today's my talk is on multicolor imaging. It's a new perspective to the imaging and documentation. First of all, like there are so many modalities for imaging retina. Now what's this new multicolor imaging and why? Multicolor imaging is a novel, non-invasive imaging modality that combines 3 reflectance images of retina to produce a composite pseudo-color image. It enables the better visualization of pathologies in different retinal layers. So how is it different from a normal fundus camera? The normal fundus camera uses a white flashlight to scan the retinal surface, while the confocal scanning laser ophthalmoscopy system uses a particular wavelength of light called as a laser beam to scan a particular area of the retina. So what are the components of multicolor imaging? It comprises of 3 wavelengths of light: the blue reflectance, the green reflectance, and infrared reflectance. The blue reflectance being the shortest wavelength and the infrared being the longest wavelength of light and has the most penetration. In a normal fundus camera, which is using the white light, we can see the intensity of the light decreases towards the deeper layers of the retina. While in the multicolor imaging, the blue reflectance sees the inner layers of retina, the green having a more wavelength of light penetrates little bit deeper to the middle layers, and the red having the deepest penetration is able to see the deeper layers of the retina really well. This is how a normal fundus image looks in the different reflectance images. The blue reflectance shows the foveal lip so very beautifully, while we can see that it is almost negligibly seen in a red reflectance image. So what are the advantages of a multicolor image? It's a high resolution and a high contrast image as compared to a fundus camera, can be taken up in a non-mydriatic eye, produces less photophobia. The 30-degree, 55-degree, and the wide field imaging are also available. And the best is that it gives a combined platform and saves time in a high volume clinics that a single machine is able to capture both the fundus camera photo as well as an OCT image. So now we'll be looking at how the clinical diseases appear on a multicolor imaging. So comparing the fundus photos, first of all, going towards the diabetic retinopathy, the most common disease in today's scenario, we can see that the microaneurysms are so well clearly defined as dark red spots on a multicolor imaging. Being found in the middle layers, they are best seen on a green reflectance image. The hard exudates are so well clearly defined on a multicolor image as greenish yellow spots. And again, being in the middle layers, they are well delineated on a green reflectance image. The cotton wool spots appear as greenish white appearance on a multicolor image. Again, they are best seen on a green reflectance image. The hemorrhages, interestingly, can be differentiated as pre-retinal, intraretinal, depending upon the wavelength in which they are seen. If they are seen more in the subretinal area, they will be highly delineated in the red wavelength. If in the middle layers, then it will be seen in the green reflectance image. We can see that the sclerosed vessels are so well clearly demarcated in the multicolor image as compared to the normal fundus photograph. Coming to the proliferative diabetic retinopathy, we can detect even subtle NVDs or NVEs which may be missed on a normal fundus photo, and maybe we may also be covering some of the patients in whom the fundus fluorescing angiography is able to detect the NVEs. And also we can see that in a multicolor image, the vascular as well as the fibrous components can be seen separately. The extent of the epiretinal membrane is so very well demarcated on a multicolor image, which may be useful in planning the surgery, like from where up to what extent the ERM needs to be peeled off. The macular edema gives a greenish hue, while the cysts appear as orange on the multicolor image. Here we can see on FFA, the extent of the leakage corresponds to the greenish hue of the retina on a multicolor image. Coming to the vein occlusions, we can see that again, the retinal edema is highlighted as greenish hue, and the cystic appearance of the macula is highlighted as orangish in this case of BRVO. And on the green reflectance image, the sclerosed vessels is so very well clearly demarcated. Now with the anti-VEGF injection, we can see there is the greenish hue decreases as the treatment progresses, and as well as the cystic space is reduced, and this orangish hue is also resolving with the treatment with anti-VEGF injections. The next disease is the central retina, the retinal artery occlusion. We can see that this edematous retina is appearing again greenish, giving greenish hue and the sclerosed vessels are again demarcated in the green reflectance. And once the retinal edema resolves with time, the thick edematous retina is replaced by a thin atrophic retina, and the loss of this greenish hue indicates the same. The early AMD changes in the outer retinal layers can be delineated on a red infrared reflectance image. The drusenoid RPE detachment can be differentiated from the reticular pseudolucens, as the leucinoid will be appearing in the infrared reflectance, while the reticular pseudolucens, being a little bit more superficial, will be more clearly seen on greenish blue enhancement. The extent of the geographical atrophy is again much more clearly demarcated on a multicolor image as compared to a normal fundus image. Being the RPE changes, it is again clearly well defined upon a red infrared reflectance. Again, the CNVM, we can see the greenish hue decreases with the treatment, and as well as the extent of the membrane, subretinal membrane, is also reduced. Similarly, in the cases of PCV, the height of the vessels and depends upon the raised areas of the causing the retinal edema, and as the intensity of the polyps and as the intensity of the wavelength passing decreases through the polyps, we can see the view is obscured below the RPE level. Again, in the cases of CSR, the extent of the fluid is so very well defined in multicolor image, and sometimes even we may be able to see a leaking spot, which we can see only on fundus fluorescein angiography on a multicolor image. This is seen over here. Again, in the case of a macular hole, surrounding the macular hole, the fluid XRF is clearly demarcated as a greenish hue, and the macular hole shows the red enhancement due to the tissue loss. The dissociated nerve fiber layer post-surgery can be seen best on the blue reflectance image. And here I've tried to classify, like in clinical scenario, what investigations we need to order if we combine the reflectance images with the autofluorescence images as well as fundus photograph. You can have a view of that. So these are my references, and then I'll say that life is just about black or white. The magic is in the million shades of gray.
Thank you, Dr. Shisha. Thank you. Thank you. I think the multicolor imaging, there are different machines. So it
Sir,
varies with
It was
reflectance also varies with the different machines.
Yes, sir.
Yeah. So
Sir,
these images are from which machine?
So these are Heidelberg images.
Heidelberg images. Okay, good, great.
So these are like pseudo color images instead of the true color images, just like we are using in topography. They are using the height of the elevated area versus the depth of the area to make the pseudo color image.
Okay, thank you.
Thank you, everyone.
Now I would like to call upon Dr. Ajay Kapoor sir for ROP in India, the alarming numbers. A brief introduction about Dr. Ajay. Sir is a senior vitreoretina surgeon practicing in Bathinda. He's currently providing services at Ramesh Eye Hospital Ludhiana, Rana Eye Hospital Ludhiana, Rajan Eye Hospital Fagwada, Brar Eye Hospital Bathinda, and Parveen Eye Hospital Sirsa. So there are many hospitals. Sir has done fellowship in AIMS and LBPI, and he's the most senior most surgeon in Punjab.
Dr. Rajvinder is here? You can do.
Hello, good morning everyone. I'm really thankful for the scientific committee for giving me this opportunity to speak on a topic which is very close to my heart, that is ROP. And for the last few years, most of my presentations have been on ROP only in various conferences. I hope I'm able to justify this presentation that I'm about to make. And slide. So what are the challenges? Before I really, tell you about the alarming numbers, I would like to tell you what are the challenges in this ROP treatments that we are facing. That today in India, we are fighting an epidemic, which is the third epidemic of ROP, but with a very limited number of warriors. The number of ophthalmologists who are dealing with this disease are too few, and the number of disease of the patients is too high. And we have poor quality of neonatal services in tier 2 and tier 3 cities, which is adding fuel to the fire. Then there are social barriers to the treatment, what I call is a Sasuma syndrome, because once you diagnose the child as having a ROP, the daughter-in-law, she goes back home and tells that child is affected by this disease. The mother-in-law says, no, do you know better than me? You have got one child and I have produced 5 children. So I know better, this child doesn't have anything, you just sit home. Then there are economic barriers for treatment and the fear of litigation, as Dr. Nishant was saying, fear of litigation and humongous compensations which are being given, so ophthalmologists are shying away from ROP. The aim of this presentation is to motivate the young blood sitting here in this room to fight against this childhood blindness. In the current scenario, as I've already told you, the burden of the disease is too high and the number of specialists is too low. And the services required is acute in tier 3 towns and cities, because you have a lot of eye specialists and ROP specialists in bigger cities and metro cities. And ophthalmic services have not kept pace with the neonatal services. You can see the mushroom growth of neonatal centers in each nook and corner of the India, but our younger colleagues of ophthalmology, they are not doing ROP screening. We need more people who can screen, little lesser who can do laser, and much lesser who can do surgery. If the first two are met with, believe me, the number of surgeries would be too less. See, this is a NICU, which is, I would say, a world-class NICU, and this is in a tier 3 town of Kotkapura. So this is what I'm trying to tell you, that NICU services have expanded, but ophthalmic services have not expanded. All the ophthalmologists are trying to concentrate is cataract, motiabind. And it's very shameful that 1/4 of world's blind children are in India. And these kids, they are sentenced to a lifelong, sentence of darkness for 60 to 70 years of their life. It is a humongous socioeconomic burden on the country. And half of these blind children, they die in low economic LIC countries. And even those who survive, they have impaired development and cognitive abilities. India also has a dubious reputation of highest number of preterm births, which is 3.5 million per year. And this preterm is less than 37 weeks of gestation age. And various studies in India have reported the prevalence of any stage of ROP between 20 and 40%. So you can imagine when you multiply this with 3.5 million, what will happen. So there was this one paper published long time back in IGO by Vinikar et al. They had extrapolated the figures from few other states to Punjab. And look, and the current present estimate that I have done is below, that because though the population is higher now as compared to their study, the crude birth rate has come down, the number of live births has come down, infant mortality rate has come down, so the survivors were less. However, in the next slide you see, they had calculated that at-risk babies were 3%, according to my estimate of 4%, because by the National Family Health Survey, at least 4% would be less than 2,000 grams, which is a cutoff for the ROP screening. 75, they have told admission of 40%, but right now, because of a AAYUSHMAN Bharat scheme, the admission rate to the NICU is 75% or even more. So hence, by doing all the calculations, their study told the number of treatable children per year in Punjab would be 36. So Dr. Nishant would be here and Dr. Dinesh is here. They can very well, agree with me that this number is a joke. So according to my estimate, this number is about more than 1,000. See, this is my own data, and this is a retrospective analysis. And here, from 2019 to 2023, in 2 centers, I mean not 2 centers, exactly in 2 areas, I have screened 1991 babies, out of which 3% or 61 babies were lost to follow after first visit. So we are having 1930 for calculations, out of which 1,102 babies had any stage of ROPs, which is 57%. As I already told you, the literature says 20 to 40% in India, but my area has higher ROP, and out of which again few were lost to follow up. Then treatment requiring babies are 455, which is 23% of the babies screened. Again, a very high number. We could treat only 363 out of this, which is 80%. Even if somebody, a few sitting in the hall thinks that maybe I'm over-treating, I'm over-diagnosing, then look here, it's the same person who is doing, but in Ludhiana when I am doing, here you have any stage of ROP which is 20% comparable to the published literature, and treatable is 7%, again comparable to the published literature. It's that area where the neonatal services are poor, the numbers are bound to be high. Again, this is a retrospective analysis for the treatments done, and look, the AP ROP and hybrid ROP amongst my babies is very high, which is not a usual feature in other published cohorts, even in ET ROP. And this is again pointing towards very poor neonatal services. This is treatment outcome that we could successfully treat 97% of babies in spite of the babies having very severe ROP. So to conclude, the state of Punjab and India has much higher number of babies requiring ROP screening and much higher incidence of treatable ROP than believed and published. And we need more young people to carry on this war against childhood blindness. AROP and hybrid is seen more commonly, which is quite different from ETROP or other cohorts. And as per me, with a little modification in ETROP, if we treat a little bit more early, we can have very good outcomes even with severe forms of ROP. And once, this is to motivate the young blood, that once you start doing ROP screening and treatments, you will, I'm saying, now you are searching for patients of Motiabin, then the patients will be searching for you, and your name and fame and popularity is going to soar and increase rapidly. So take up this fight against blindness, and don't be disheartened, because koshish karne walon ki kabhi haar nahi hoti. And I am here to teach this art and science to anyone who is interested. Thank you very much.
Thank you, Dr. Ajay. I think that's a very important message for everybody. And I think it should not be restricted to retina specialists doing screening only. No, I think everybody can, and everybody and anybody and everybody who is interested in learning how to do a screening should not shy away just because there have been some adverse code.
See, screening is the backbone of ROP. In my series, stage 5 and stage 4 numbers are so low that it's all because they were screened and we never allowed the children to reach stage 5.
I was actually astonished at like it doesn't even form in some big institutes. The pediatric ophthalmology fellowship also does not constitute a ROP screening program. So I think pediatric ophthalmology fellows should at least be part of a screening program.
Exactly.
Most of us doing screenings, I've been doing it for more than 25 years now, are not doing the surgical part of it. But by screening early and by doing medical treatment, we are able to reduce the burden to quite a bit, and then there are only few cases which need to be referred, and they are at least under your supervision.
Exactly.
So we can take care of this. The only motivation, as the last wordings by Ajay Kapoor, koshish karne walon ki kabhi haar nahi hoti.
Thank you.
Thank you, Dr. Ajay. And next speaker, Dr. Rajvinder. I think Dr. Balbir could not come, so another important topic as far as retinopathy of prematurity is concerned, medico-legal aspects of ROP, do's and don'ts. In fact, more than ophthalmologists, even pediatricians are nowadays scared. So we do get patients for screening, kids for screening who are 2700, 3000 grams and all.
Yeah. That was a shot in the arm actually for ROP screening.
Respected panelists and respected faculty and delegates. On the behalf of Dr. Balbir Khan, I will be speaking on medico-legal aspects of ROP. After the talk of Dr. Ajay Kapoor sir and Dr. Nishant Bhatt sir, and Dr. Ved sir and Dr. Dinesh Garg's comments, many things have been covered already. So I will be briefing just a few cases. So this is a case of that is a Amritsar couple who has won the case, and it is a good news for the pediatrician as well as ophthalmologist, as previously every case was compensation was charged, that is 2 crore or 1 crore. But in this case, that is 50 crores against the pediatrician as well as the ophthalmologist. So just briefing about the case. That is 1700 grams, 750 gram of weight. That is with the history of sepsis. ROP screening was done within 4 weeks of NICU. And 1500 gram baby screened in OPD 5 weeks after birth. So both were advised 2 weekly follow-ups, means the proper documentation was done. But the parents missed. And the 6 months later, the child developed the 5-stage ROP. And it was diagnosed at the same institute. So the compensation was not granted because in this case the proper documentation was done. So even the ophthalmologist and the proper screening was done at the right time. So in this case the compensation was not granted. So learning in this case that the proper documentation is very important. So the national consumer did not award any compensation to the parents because that they even accepted the OPD records of the hospital where it was well documented that the retina is immature and needs regular follow-up, and if it develops the ROP then it will need the treatment. So the advice that ROP should be done in NICU or the laser should be done in NICU whenever it is advised by the ophthalmologist. And even the OPD records, we should document each and everything on every visit of the child. And on every visit, once we are following up to the 42 weeks, they should be counseled the proper follow-ups. And it is that is if it is in zone 1, then we have to do the screening, that is weekly. And if it is in the zone 2, the immature vessels, then 2 weekly. And if they are in third zone, then 3 weekly. And if the patient is very small baby, like the 26 weeker or the 28 weeker, then before that also, normally we recommend 30 days of screening, of 30 days of life. So in these cases, maybe the 15 days of life should be screened. So lessons to be learned, screening should be done on 30 days. And whenever there are 26 weeker or 27th weeker, it should be done at the earliest. And OPD records are well accepted and should be well maintained. So, so the second case, that is the second case from the Patiala, that is where the anesthetist was the owner of the hospital and the pediatrician was involved. And it was in 2005 when the 750 gram weight baby was and 27 weeker. He was on ventilator for 4 weeks, and the examination was done on the 5 weeks and by the ophthalmologist, and he was told about the immediate treatment and he was referred to the higher center. But the parents they did not went on time, and after the child went to stage 5A where the child needed the surgical treatment. And after the surgical treatment, and patient while in surgery he went sick, and again after that the life of the child could be saved. But after the 2 years, then the case was the parents complained for the case, and the National Commissioner Court awarded 25 lakh compensation plus interest. So now the case is in the High Court, and because the pediatrician and ophthalmologist and pediatrician, they failed to notify the parents about the strict follow-up. And but in this case, the ophthalmologist is not involved, because when he was referred at the time, he was diagnosed and he advised the treatment. So it is very important that whenever any ophthalmologist receive the call for the ROP screening, pupil should be dilated, and it should be done with the speculum and with the indirect ophthalmoscopy. We cannot do with the direct ophthalmoscope, or undilated ROP screening should not be done at any case. And ROP follow-up is to be mentioned on discharge card clearly with the date. And head of the hospital and the owner, they are equally responsible for the missed ROP. So the duties of the ophthalmologist, that is information to be communicated verbally and in writing and in their own language in which they understand. So the critical time is the window period. So counseling for zone 1 is very important. In some few patients when we inject, and there is the chances for the recurrence. So they should be told that even after the anti-VEGF, the child may need the that is surgery as well as the laser. So they have to follow up once on every follow up. They should be counseled and they should be given a chair time. So reactivation is possible even after the injections and even after the laser in few cases. And if you are in doubt, you can always refer for the second opinion and document your conversation with the parents in physician notes. So no child is born blind from ROP. Screening is safe even for babies who are on ventilator. Do not deny ROP screening for babies who did not receive oxygen. Do not deny ROP screening in larger babies. Follow Indian screening guidelines. Thank you.
Thank you, Dr. Rajendra, for an excellent presentation on behalf of Dr. Balbir Khan.
I hope I could justify.
Of course, yes, you always do. So before we go on to the next talk, I think we can have the discussion on ROP because it's very important, and I think the session should have been named ROP session only. So before we start the discussion for 5 to 7 minutes, I have a few comments on this your talk. One most important point which you already mentioned was that always keep the records of the baby in the hospital also. Do not hand over all the records, even if it's for a screening only. Because in Punjab only, I don't want to name anyone, something happened that they gave all the records to the parents and the lawyers kept whatever suited them and they threw away whatever did not suit them. We do not want that to happen, and that's why they had to pay a humongous, to quote your word, compensation. So keep the records yourself, and always I have made a stamp like with what you dilate. Okay, diluted drops make a stamp. Sisters will forget to write. And eye drops, antibiotics, because in LV Prasad only, such a top institution, sorry, there was a educated couple who brought a child, and the child developed a very severe conjunctivitis. They filed a case against the LV Prasad Eye Institute, Hyderabad, then several years ago, and there was a lot of harassment. There was no compensation, but it's only harassment. Okay, if you have written antibiotic drops, written, not written is not done. That is one point. Second, very important point which most of us are not aware is that we have to keep the records of the children for 21 years, not 3 years like any medical records, because 3 years is for that medical record and 18 years the child becomes adult and he has a decision to make for himself, and so 21 years. So electronic medical records or whatever you want to do. Second point is that we do lasers. Many of you are doing the lasers. So after the laser, do not send the baby home immediately. Okay, they can go into apnea. We have seen our children going into apnea after laser. Let them sit at least for 1 hour, maybe 2-3 hours, and the anesthetist should always be there. And you should know how to use an ambu bag. Let him teach you how to use an ambu bag. Okay, this is very, very important. And that's all. Now we can have the questions from the audience and comments from Ajay and all those people who are doing ROP. Dr. Taran is also doing a lot of ROP.
I have one very silly question, it might be. Dr. Nishant Bansal. Sir, I saw your video. You were injecting with 30 gauge needle, as we all do. It's just my question only. Whether the hub touches the sclera or it doesn't. Yes, I just saw. So I just want a opinion from audience and Dr. Vig and who all are practicing ROP. So in adults too, we are touching the hub to the sclera. In ROP practice, are we careful like not touching or we are maintaining distance? Because I am touching the hub to the sclera. That is why it's my question.
Yeah, I think the full penetration.
Okay.
And the smaller needles are available. I've never used them, but we use about partial thickness injection. It's always inside the eye. And as you said that rightly so, we do not go like this. We go towards the
near
ground.
the optic nerve. And sir, Dr. Ajay, sir, you are also maintaining distance from the sclera or you are with the 30 gauge needle?
I don't use 30 needle. I use the insulin syringe.
Insulin, so
Yeah.
same here.
Yes.
Me, I also
Yes.
use insulin.
So-
And
so
sir,
that's-
Dr. Vic, sir,
Yeah, I use the regular 1 ml.
30 gauge?
I use 30 gauge, but I don't go full.
If you're using 30 gauge, you don't have to go full.
Okay.
And
Really,
I
sir?
think even for adults, you don't have to go full.
For adults,
Yeah.
we don't do. Yes.
Even for adults, we don't go up to the hub.
Yeah, it's
There's
not
no
required.
need.
It's not required.
Dr.
You just
Nishant,
make sure that it is inside the vitreous cavity.
Dr. Nishant, in your videos, pupils are
No, for injection also we do dilate.
yes, we do dilate. It's required
Yeah.
for two reasons. Number one is visualization of the bolus of the drug going in, because many times you
Yeah.
are falsely injecting it outside, so you know that yes, you have injected it inside.
But sometimes the people do not dilate because of the anesthesia. But next day it dilates beautifully. It's such a wonder.
Yes.
VEGF, anti-VEGF.
I usually don't dilate all the time. Yeah.
My question is, if we are using insulin syringe, so how we are taking the injection? By removing the cap and the rubber
Yeah,
directly?
That is the issue.
That is the problem.
With
That's
the
why I would not
1
use it.
cc, sorry to interrupt. With the 1 cc, if we can take and we remove the hub, and from the top part we can take from the insulin syringe rather than touching the vial directly.
But with the insulin syringe, that is very thin, na? So it
Yeah,
will, I think.
there is no hub, so that is whole idea of just saving the.
No, but then you have to penetrate the rubber with that that particular
it
needle
will
only.
go
No?
like,
No, I'm telling we take with the 1 cc syringe, remove the hub, and from the top of the 1 cc syringe we take from the insulin, so the sterility is maintained.
From syringe
Syringe
to
to
syringe.
syringe.
And
This is
we-
what I practice. I don't
We
know.
use the indirect light because by the time you get some experience, you are presbyopic already. So I use the indirect ophthalmoscope light and then I inject because there are no microscopes in the NICU.
Yeah, of course, that is there. But yeah.
One more question. Sir. There are many companies who have launched the ROP drops. One is
Yeah,
Arcane,
Semi,
I know. So
Semi.
any experience from the audience side or from the
I am not
chairperson?
at all happy with them. Yeah,
Okay.
same here.
Thank you, sir.
Same here.
Just one comment. Initially, when I started giving injections, I was doing in OT setup. But that was very tedious because taking the baby from NICU to OT, the OTs were very cold, and if the babies were on ventilator, sometimes the tube used to move. So now I've started doing the procedures in NICU itself. So it's very comfortable, and the baby are there in the warmer. So I've changed my practice over
So
the
if
years.
the child is still admitted, you can do it in the NICU. I don't think there should be any issue about with that. So it may be a outdated practice, but even for adults, I do dilate the pupils and I do see indirect ophthalmoscopy after injecting. I don't know if everybody does that. Yeah, that's
You can.
yeah.
I still give most of my injection 90% in the OR. I'm more reluctant in NICUs. If the child is on ventilator or very sick, only then I give in
Same here. I do it in the NICU
Rather,
only if
last
I have
night
to.
only I had to give one in the NICU, and once I give in the NICU, my BP is very high. So I
If
don't
the
want-
child is admitted in NICU, then I don't think we have
No,
much
so,
option.
he may be
Yeah.
admitted but not sick. So then,
Yeah.
then I ask them to transfer the child. Otherwise,
That's okay.
if child is on ventilator, then in NICU.
Yeah, I
we,
inject.
we all have our own practices and our own comfort zones. It's equally
I
good.
agree with you. That's
So
what
I
do.
think
Sir, one question. So post injection, usually we prescribe antibiotics only.
Yeah.
And steroids in any case?
no need for steroids.
In
I
NICU,
think
you just-
do we need to discuss about the camera screening and things like that, because that's one part probably which might be able to take care of the burden which we are talking about, but still there is, like, I don't use it myself because
I'm also not using it.
because I had some issues with the quality of the photographs and things like that. So, but those standardizations are coming in. So maybe in future we have that kind
We
of.
are getting more cameras now. More cameras are coming, so
Yeah.
maybe better.
We
imaging will
might
be
have
there.
some.
Yeah.
Yeah, I don't use the cameras either.
So can we go on to the next?
What about the indirect video cameras linked to indirect ophthalmoscope?
No, you can take a pic with that. That's not an issue. That should not be an issue. But the issue is that an ophthalmologist is doing it, not a technician. So in the cameras, the technician is going around in the NICUs and doing the screening,
With the indirect,
and you are reporting.
eye surgeon would be required with the indirect. But what sir is telling us is about that. Tele screening.
So we go on to the next talk. Yeah, this is.
The next speaker is Dr. Anjani Khanna. She's going to present to treat or not to treat insights into pigment epithelial detachment management. Just a brief introduction about ma'am. She is currently a senior consultant Retina at Grewal Eye Institute, Chandigarh. Her areas of interest are vitreoretina surgery, diabetic retinopathy, ARMD. She has 11 publications to her merit. She has been awarded Gold, this is a Young Researcher Award in 2014, and Dr. Prem Chandra Gold Medal for Best Paper and Poster in Northern Ophthalmology Society Conference. Okay, ma'am.
Thank you. Very good morning, everyone. I would like to thank the organizers for making me a part of this prestigious conference and this informative session. Now, switching a little bit from small babies to elderly population. A lot of times in our retina practices, or even as anterior segment surgeons, when we are screening our patients for cataract surgery, we can come across this large drusenoid pigment epithelial detachment. You do an FFA ICG, there are no leaks. So I want to know the opinion of the practitioners here as to what would you do. So how many of us would like to inject an intravitreal anti-VEGF injection? No one? How many of us would do a laser plus minus and anti-VEGF injection? How many of us would observe? And how many of us would refer to someone who can manage it better? So we'll hopefully reach some consensus at the end of the talk. Just going to show how we managed a few of these cases. So this was a 59-year-old female with recurrent episodes of uveitis in one eye. She had developed a PSC in one eye. She has a significant history of AMD in both her parents. Both the eyes showed large PDs, drusenoid PDs, and all we did, as few of our practitioners said, we ruled out a macular neovascularization here by an FFA and ICG. OCT angiography also confirmed there was nothing lying there, and all we did was observe. So she was followed up for 8 years. We can see the PD is now gradually increasing in size year by year. It is accumulating some subretinal fluid at the top of it. There are some hyperreflective foci intraretinally, and the PAD has enlarged to a point where finally it started to collapse. So the PED ripped on its own, collapsed, and finally the patient had a vision of 1/60 accompanied by a complete RPE and outer retinal atrophy. What happened to the other eye? In these 8 years, the other eye, which had also presented with this PED and some subretinal fluid, gradually started decreasing in size. The fluid went off, the hyperreflective foci went off, and to our pleasant surprise, she was 6/9. The PED had completely resolved, and the patient is till date maintaining a good visual function. Another patient with both the eyes PED, been following her up for 4 years. The right eye is showing some alterations in the PED height and size. When we look at the left eye, that PED again completely resolved. So we can see a near normal outer retina, subfoveally and temporally. Nasally, there are just some drusen. The vision is still maintained to 6/6. Another PED followed up for 3 years, resolved completely, and the vision is 6/6. So what do these eyes teach us about this pigment epithelial detachment? Intermediate AMD can present with drusenoid pigment epithelial detachments without any presence of a macular neovascularization. So all we need to do is observe in these patients, do serial OCTs, serial FFAs, ICGs to see whether any MNV is developing. It can either progress to an MNV, and that is when we start treating them with an anti-VEGF injection, or progress to atrophy on their own, even regress with retaining normal function. But what about this subretinal fluid? We saw there was a subretinal fluid on top of that PED. Then why don't we treat with an anti-VEGF injection? To answer this question, the big names of retina came together and came out with 3 patterns of this subretinal fluid. They said we can find it at the top of the PED, at the side, or as a drape over a confluent drusen. Now, this is not due to macular neovascularization. This is due to sheer separation of the RPE from the Bruch's membrane, which loses its blood supply, and at the top of the PED, those RPE cells can no longer function, and so they can no longer pump out the fluid to the choriocapillaris. So this fluid has just to be observed. Most of this will lead to atrophy. Some may even regress, but these have not to be treated with anti-VEGF injections. Why not laser and or use with an anti-VEGF cover so that these lesions can disappear? Well, people have done that and also shown that these PEDs regress, but so have we. We didn't do anything and the PED beautifully regressed. The second thing, it is not indicated in such patients, and giving a laser or an anti-VEGF in such patients may actually increase the risk of RPE rip. So such tense PEDs, if you go in, there's high chances of an RPE rip, and it can also actually lead to a faster progression to atrophy. So now what would you do? Give an intravitreal anti-VEGF injection, do a laser plus minus anti-VEGF, observe, or refer. So we still seem to have a consensus because no one is answering. So the answer is observation. 59 years. One eye anterior uveitis. No, nothing like that. She was HLA B27, recurrent episode. We will just give topical steroids. That's all.
So many of these patients, they are on some sort of systemic treatment or something which increases their choroidal permeability, increases their choroidal permeability. So these patients I treat with spironolactone or Epicus tablets, 25 milligram BD for around a month. I give a trial, and many of these patients respond. Once they start responding, I keep an observation, and if there is any peaking like that, I inject, and they are doing beautifully well with the latest injections like Pebismo or Eylea. They are now in current era. I don't wait. I inject most of them after giving this trial and keeping them under observation, explaining them all the things, giving them this, and I have not have any rip in the last many years.
Dr. Ranjit, be ready
That's
with
what the paper said, that these PDs, if we do a multimodal imaging, since now we, most of us have OCT angiography or an FFA or an ICG, if there's no macular neovascularization there, we don't have to do anything for these. These will take their own course. So I'm talking about AMD patients, not uveitis. That was just that finding.
I'm telling of AMD patients only. If we leave them, they are going to have RPE atrophy, because in these last 25 years I've been following these patients. Earlier I was not doing anything, but now with the latest injections, long acting injections, we are getting these PDs suppressed, and they are having better vision as compared to the other.
Can we have the discussion after the?
They will come down. No, I'm not talking all, but many of those.
Dr. Mali will have
we
the
are
next.
short of time. Let's hear our guest rheumatologist.
Conclude.
Dr.
Actually,
Dr.
I wasn't
Ranjit.
finished.
Oh, okay.
So I just
Now we can have the discussion over
just
a cup
1
of
second
tea.
more.
Yeah, sure.
We are done.
Yeah, please.
So what we would say and what we would advocate is observe these patients, and as teenagers we were told not to puncture the pimples that we have. Ladies and gentlemen, let's not fiddle with these PDs which can actually regress or atrophy on their own.
Yeah, good. Very nice.
Thank you
message.
for your kind
Good.
attention.
Very nice. So last but not the least, we invite Dr. Ranjit Kaur. She's a rheumatologist, and I invited her on a request. And she was on the faculty of Guru Ramdas Hospital, and now she's on her own, and she runs a pain clinic in Amritsar. She'll be speaking on rheumatology and ophthalmology.
Good morning, everyone. Thank you so much for this opportunity. Today, the topic of discussion is ophthalmic manifestations of rheumatological diseases. To introduce my topic, I can say that ophthalmic diseases are often associated with rheumatological disorders. Eye is an important indicator of many of these diseases. It can be one of the earliest organ to show disease activity, and these diseases may manifest as variety of ophthalmic conditions with wide range of signs and symptoms. So the common ocular diseases are keratoconjunctivitis sicca, episcleritis, scleritis, uveitis, keratitis, retinal vasculitis, and optic neuritis.
Next slide. Slides are not moving.
Sorry,
Slides are
I
not
did
moving.
not. Right.
Slides are not moving.
All right. So to talk of keratoconjunctivitis sicca, we know that most common autoimmune cause is primary Sjogren syndrome. Rheumatoid arthritis and SLE, they causes secondary sicca. Regarding episcleritis, most of the cases are rheumatoid cases. For scleritis, the common causes are rheumatoid and GPA, previously known as Wegener's granulomatosis. Regarding uveitis, in rheumatology, anterior uveitis is most common, followed by posterior, pan and intermediate uveitis. Common cause of anterior uveitis is HLA-B27 associated arthropathy, which is a big spectra comprising ankylosing spondylitis, reactive psoriatic, IBD associated arthritis. Second most common cause is juvenile idiopathic arthritis and Behçet's disease. If we talk of intermediate, pan and posterior uveitis, Behçet's and sarcoidosis are the common causes. If we talk of PUK, the common rheumatological causes are rheumatoid, again GPA, pan and relapsing polychondritis. So now we'll be talking of few diseases, common rheumatological diseases and common ocular findings of these diseases. As we know, rheumatoid is a chronic inflammatory arthritis. The ocular disease and the severity of this ocular disease, it depends upon the RA chronicity and resistance to therapy. The common ocular symptoms in a case of rheumatoid are keratoconjunctivitis sicca, episcleritis, which is mild and benign, scleritis, which is more severe, leading to scleromalacia perforans in severe long-standing cases, PUK, which is seen in severe and active RA. So there are many publications on ocular manifestations of RA with different forms and frequencies, and the similar results have been postulated. To investigate such a case, if you find a case of rheumatoid and you have these ocular findings, kindly order RA factor, anti-CCP, ESR and CRP. If we talk of treatment part, treating the underlying RA effectively, that is crucial to manage the ocular complications. Coming to juvenile idiopathic arthritis, a child coming to you less than 16 years of age with arthritis lasting more than 6 weeks, we classify into 7 subtypes, but of importance to ophthalmologists are oligoarticular 1 and RF negative polyarticular 1. So uveitis usually presents after arthritis, but in 3 to 7% of cases, it may develop before arthritis. It presents as anterior uveitis, which is chronic and granulomatous with posterior synecdoche, band keratopathy. These ocular findings, they are more common in oligoarticular GIA form and ANA positive girls. To investigate such a child, kindly order a CBC, rheumatoid factor, ANA, which should be done by immunofluorescence, and HLA-B27 to be mentioned to be done by PCR method, not by flow cytometry. Treatment for this case, first line agent is methotrexate apart from the treatment which you are doing for the ocular part. In severe GIA associated uveitis, combine methotrexate with adalimumab. So early introduction of immunomodulatory therapy is the best way to prevent complications, and similar results have been published regarding biologic therapies for GIA associated uveitis, where methotrexate was the first line corticosteroid sparing agent. If we talk of Sjogren, ocular findings, keratoconjunctivitis sicca, recurrent conjunctivitis, filamentary keratitis, corneal ulcers, blepharitis. So apart from the ocular diagnosis, kindly order ANA, anti-SSA, anti-SSB and a labial salivary gland biopsy. If we talk of treatment, we do not have much to offer. Pilocarpine is the drug which we can add. Otherwise, anti-TNF and anti-CD20 rituximab, they are under trial for the treatment of keratoconjunctivitis sicca in Sjogren's disease. A big spectra, spondyloarthropathy, which usually presents as acute anterior uveitis, which is sudden, unilateral, recurrent, alternating between the eyes and often associated with HLA-B27. So it's a big spondyloarthropathy comprise all these kinds. So it is either psoriatic or reactive, IBD associated. It may be ankylosing spondylitis or it can be undifferentiated spondyloarthropathy. Suspect if you find a psoriatic plaque on the extensor surfaces of the body, or if you find a male patient with arthritis having a stoop posture, kindly order HLA-B27 by PCR, not by flow cytometry, X-ray pelvis to look for sacroiliitis, ESR and CRP to look for disease activity. Treatment for such a case is corticosteroids in severe refractory bilateral cases. Treat such patients with DMARD with sulfasalazine as drug of choice, followed by methotrexate. Biologics in the form of infliximab, adalimumab, anti-TNF drugs are drug of choice. Etanercept should not be used as it is associated with paradoxical induction of new onset uveitis. If we talk of Behçet's, ocular disease is present in 40 to 50% of cases with uveitis, recurrent bilateral non-granulomatous and development of hypopyon. It's a sight-threatening disease. Suspect Behçet's when you have recurrent oral ulcers and recurrent genital ulcers. Apart from the routine test, kindly order HLA-B51, which is associated in 50 to 80% of cases. And treatment here is corticosteroid, where methylprednisolone pulse is given in severe life-threatening flares. Systemic immunosuppressants with azathioprine, cyclosporin and mycophenolate, and definitely there is role of biologic therapy here. Lastly, GPA, it presents as orbital disease, scleritis, PUKs, retinal vasculitis. Suspect such a case if you find a saddle nose deformity, hearing loss, kidney involvement and upper airway involvement. Order CNCA and PNCA apart from the routine blood test. Histopathology will be necrotizing granulomatous inflammation. In such a case, we treat with systemic corticosteroids. We induce our patients with either cyclophosphamide or rituximab and then maintenance therapy with azathioprine, methotrexate and mycophenolate. So there are many studies for cyclophosphamide and rituximab treatment of scleritis and uveitis in patients of GPA. To conclude, I can say that these ophthalmic diseases are common in rheumatological diseases which may range from mild to sight-threatening, and these early manifestations serve as sentinel signs. Severe complications can lead to permanent vision loss, so regular ocular screening and early immunosuppressive therapy improves visual outcome. Thank you.
Thanks a lot, ma'am. Thanks for coming and enlightening us about the rheumatology part of it. I think with this we end the session as we have already, I think, couple of minutes more than the allotted time. Thanks a lot for everybody staying till the end of the session. Thanks.